of care safer. So our goal for today is to have everyone understand the importance of high quality transitions of care, recognize where intervention is needed to improve those transitions, and finally identify interventions that can positively impact these transitions of care. And before I keep going about transitions, what are transitions of care? And so it's basically movement of patients, and it can be within settings. So if you are in the hospital and you move from the ICU to the acute care unit, you have a transition. If you are in the hospital and you're leaving to a skilled nursing facility, you have another transition. If you have, in the outpatient setting and you're seen generally by a primary care provider and you're sent to a specialist for a recommendation on heart failure, for example, you get another transition. And also there's transitions that aren't necessarily physical across providers, but it's more about your personal experience of care. So transitions across health stage. So someone who has been getting acute curative care for their cancer, and now the chemo is not working anymore, and they change their goals of care to more comfort-based instead of curative-based. And so there's so many different places where we can talk about transitions of care. I wouldn't be able to talk about all of them in one go. So I chose to speak about transitions of care between different settings. And even between different settings, there are so many places to go, right? So you can talk about when someone comes into the hospital. So if they leave their home or skilled nursing facility to come to a ER, or if they're leaving the ER to go back home or to a skilled nursing facility. And when I say home here, there's many different types of home. So I'm not separating home by yourself or home with their caregiver or an adult family home or assisted living facility. Home is home. And I'm just making it separate from an institution setting like a skilled nursing facility. But other transitions include, I guess, I put home to inpatient, which of course you have to stop through the ER, but that admission process is like a little bit more complex. And then again, from the inpatient setting to home and to a skilled nursing facility. There's also another important point in transitions, which would be from the skilled nursing facility to home. But because it's a little bit separate issue as well, I didn't address it here today, even though in many ways, the transition from a skilled nursing facility to home will be similar to a transition from the hospital to the home as well. And so I mentioned that there are many models of transitions of care. And so, in the recent years, transitions of care has had a lot of attention. And, there's actually, you can study transitional care. I guess I can't say it's an area of medicine, but it's an area of study, transitional care. And as everything that we study, people develop lots of different models to study it and ways to address it. For the models of care, you can have different focuses. For example, you can focus on from discharges from hospital to home. And this is really where most of the studies have been done. And the hospital to home focus is, is in hospital to home and hospital to SNF, but hospital to home focus is trying to address the readmission problem. Right. And then, so you can also have different timings. So some studies look at patients at up to 30 days after discharge. Some look at up to 90 days after discharge, and very few look at long terms. And then also when you look at models of care, there's different transition facilitators. So basically who's responsible for that transition and who's responsible for helping the patient through that. And so it's often driven by PAs and ARNPs, pharmacists, social workers, nurses, which is missing there, but it's also very important. And the physician's part has an asterisk there, because really when transitions of care have been studied, generally the physician is removed from it. I think everyone is trying to do things to how can we make transitions safe without necessarily having to involve the physician in the team. And there's many different reasons for that. Physicians maybe are higher paid than other people. Maybe it's just because they have a different focus already, and you already have so many other clinical duties that it's hard to integrate transitions of care. But as physicians and nurse practitioners or providers taking care directly of the patients, we are really an important part of the transitions and of the healthcare system. So I think it's important that we also think about this and talk about it. And then, so why work on improved transitions of care? There are so many things to work on in any setting that you are. So, if you're in the hospital, working as an inpatient doctor, there are so many things to work with inpatient transition. So from day team to night team sign outs, from ICU to acute care. So why focus on these transitions from out of the hospital? And so for us, in geriatrics especially, older adults are vulnerable to fragmented care. And not only because, they may have more comorbidities and may need to see more different specialists. So they may have specialists across health systems and where the records don't necessarily connect. So you may have fragmentation there. Our older patients tend to have more specialty visits, right? So you may have also more conflicting information. So you may have the cardiologist saying, increase the Lasix, the nephrologist saying, decrease it. And ideally, in the ideal setting, you would have consultants talk and everyone come to an agreement about what the best plan of care is for each specific patient. But we all know that it doesn't always happen, especially when you're leaving from one place to the next. And then there's also the financial barriers for transitions of care. For example, patients who are leaving the hospital and go to a skilled nursing facility, and they're advised to come back to see a specialist, right? So I see lots of orthopedic patients who have hip fractures and they go to a skilled nursing facility and they're supposed to come back to see the orthopedics team, get x-rays to see how their healing is going, remove the sutures at that point. But then to come back from the skilled nursing facility to the hospital, they actually have to pay for transportation. If they're not mobile enough yet to be in a private car with their family, they have to pay for a cabulance. It can be hundreds of dollars for each visit. And so that is certainly a barrier in that transition, right? So sometimes patients will decide, well, I don't want to go back to that appointment because I can afford it. And then poor coordination of care, across settings can result in rehospitalizations. Again, if you aren't able to follow up with the plan and to have the proper follow-up, you may have to come back to the hospital. And so delivering high quality patient-centered care really requires coordination between many people and coordination between many providers. And so, improving health. And so with good transitions, we can improve health outcomes, not only survival, but also quality of life and perceived quality of care as well from the patients. And so hopefully we can prevent some readmissions and also reduce healthcare costs with that. And when I speak about preventing hospitalizations, it's just the preventable ones. We all know that sometimes things are beyond our control and patients may need to come back, and that's okay. But if we can help avoid it, then it might be better. And then, like I mentioned, there are so many places in our system where we have different transitions. So why focus on hospital discharge? For me, particularly, it's because, like I said, I see patients from both sides, from the SNF in the hospital, from the skilled nursing facility perspective. I really see when things break down. And of course, it's easy to see things after they happen, right? So in the skilled nursing facility, I get to see after things don't work well with the transition, what consequences they can have. And from the inpatient side, we're always trying to focus on proper transitions, but I'm sure that, none of us, at least I have never gotten any transition completely perfect 100% without missing anything. And so being aware of those issues is helpful so that we can double check and triple check them. And the hospital discharge is a multidisciplinary process. Like all of you know, we have from the medical field side, you have the physicians involved, and then you will have a care coordinating nurse or social worker. You'll have to coordinate with the receiving facility, or if someone is going home, you have to coordinate with the home caregivers, with maybe a home health agency. And so there's lots of people involved in this process. You have to, and so many decisions are made. So another issue is that many decisions during hospitalizations are made without fully involving patients in that. And again, it's not malicious, it's part of, part of being in a busy day. But if we think about it, even if you try to always make sure patients know everything that's going on, I'm sure all of you who might work in an inpatient setting can remember sometime when you changed something to a patient's plan of care and didn't tell them. Either be it, changing their outpatient felodipine for the inpatient amlodipine because that's the formulary, or repleting their potassium because, it was low in the morning labs and not even thinking twice about it, or decreasing their diuretics after you saw results, and then you discussed them with the team and just made changes and didn't necessarily go back. And so, because all these things happen in the inpatient setting, when the patients are leaving, you kind of have to reconcile all of that, everything that happened, and make sure that patients are involved. And so another reason to focus on the discharge is because 15% of Medicare patients are readmitted within 30 days, and maybe a quarter of those admissions could be prevented. So because of all the money involved, I think that's where lots of legislators and lots of the big systems have been working on the discharge, hospital discharge. From our perspective as clinicians, yes, we want to save healthcare dollars, but also we want to make sure that our patients are safe when moving from one place to the next.
Isabela, when you say Medicare patients are readmitted, is that like the heart failure data, or that's just all Medicare admissions?
What I saw, it was all Medicare admissions.
Okay. There's those classic groups that get readmitted because of, because of a bad transition. Just wondering.
Yes. Yeah. So this one was all Medicare admissions, and I can look it up where I got it from later if you like. I forgot to put the reference here. I left it in another slide. Yeah. And so, to know where to intervene and what to avoid, we need to know where the problem is. And so, a few main places where the cracks happen. One is medication continuity, which, is medication reconciliation is the big part of it. The other one is the medical readiness. So we're striving for shorter hospitalizations, even though we don't always get it. But, I think that as the years have passed with better supports and post-acute care systems, we have, and hospitals being full and trying to decrease hospitalization days, we're striving more and more to get patients out of the hospital soon. And so we really have to make sure that patients are medically ready, and that's where this comes into place. Mobility readiness, and this is, you have to be mobile enough to get to your next level of care. Discharge instructions for patients, discharge communication with other medical professionals, because when we talk about discharge instructions, there's the things that we tell the patients, this is when you should come back, but also there's a piece of communication that is related to, communicating the care that they got in the hospital with their primary care doctor or with a specialist that they're going to see afterwards. And then, there's also the lack of information for patients about what to expect after discharge. And I think that as an inpatient team, we often don't think too much about it because, we talk about how, you're going to go to a skilled nursing facility, and it's a big black box for many people that we don't think too much about. And so we also don't tell patients too much about. And then, of course, there's also equity issues with who gets access to the best transitions and to the best care afterwards. And then, other risks of, this is just like a risks of transitions. And this was like, as I was doing my research, I found this article. It's a JAMA article, like JAMA Network article, and it was an investigation in geriatrics about intensification of diabetes medications at hospital discharge in older veterans. And basically, they saw that when patients came into the hospital, they had their diabetes regimen intensified because they were hyperglycemic for whatever reason, they're sick. And then at discharge, they had more hypoglycemia because they left on higher doses of insulin. And it actually didn't improve their long-term outcomes in terms of A1C control. So we think in the hospital that we're doing this such great job because we optimize their regimen and we're going to discharge them and they're doing so well. But we forget to take into account sometimes that after they leave the hospital, things change, right? It's a different setting, different environment, and different situations. And so this is not necessarily a study about the transition itself, but it still is because the patient, it just shows the risks of having many transitions, right? They had an outpatient person who was taking care of them, and then they went to the hospital, they got a different team that's taking care of them and leaving without necessarily communicating with the primary care provider. And so they get these different medications. So successful transitions of care, begin at the time of admission with early assessment, requires many people involved. Patients and families should totally be involved in planning. It goes better for everyone if they are involved early on. It requires clear communication, and a lot of patient and family education is involved. And so even though this is not a clinical topic, I still decided to talk about a fictitious patient, Mr. F. The picture is of my grandfather. My brother painted this at some point for celebration. So so Mr. F is an 80-year-old man admitted to the hospital for right hip fracture because he fell at home. He has diabetes, now known as osteoporosis, and he also had a recent cataract surgery a couple months ago. So when he came in, you asked him about his home meds. He said he's on Glargine 30 units daily and Lispro 10 units TID with meals. He denies having any problems with his regimen, and so so we'll come back to that. And so when we talk about medical readiness, what does that entail? So one is that if you're discharging someone that needs specific follow-ups, you have to ensure that they're able to get the follow-up in a timely manner. So if you think someone is medically ready to discharge, but they need, some labs and they have to be done in 2 days, you have to know if the place they're going, they can get labbed in 2 days. So if it's a Friday and you're sending them home to get labs and it has to be on Sunday, really, are they going to be able to get it, right? So if maybe they're not medically ready to go, if you need such close follow-up and there's not a place to do it. And then you should have a plan for follow-up of pending results. So many of us know at Harborview, for example, if you order a vitamin D level, it's not processed every day and it may take a few days to come back. And so if your patient leaves and the lab is not back, what do you do with it? Yeah. Right. So do you just leave it there? So have a plan. And so also, again, understanding where the patient is going and what resources are available. If they're going to a skilled nursing facility, it's probably easier for them to, have that lab done in 2 days, even though there's other barriers to that. But if they're going home, from Seattle to Orcas Island and they have to come back for follow-up here in 2 days for an appointment with a clinic, again, we have to rethink that. And so Mr. F, about his medical readiness, he felt fine other than his poor appetite. Okay. They came, you came to say hi. Okay.
No, you didn't.
Hi. And
Okay.
okay. Have a good day, honey. Love you. Thank you. Okay. Sorry. Yeah, it was Portuguese. So she said, no, we came to give you hugs. So yeah, so so Mr. F.
Care.
Hmm?
That was a transition of care. There you go.
Right, transition of care. Yes, they're leaving home to go to school. But yeah, so Mr. F, so other than his poor appetite, he felt very well. Labs were fine. He felt, able to drink enough to stay hydrated despite not being able to eat too much because he's in the hospital. So that part for him, he felt that it was not an issue. So the second topic would be the medication continuity, or in this case, medication reconciliation. And this is a topic that's very dear to me because, again, receiving patients in a skilled nursing facility, and I think a lot of this has been, in our system, for example, has been exacerbated with Epic. I think that beforehand, maybe we didn't get the medication reconciliation all done, but also we might not know all of it. Now, with the more that EMRs are integrated, you have more information, right? So you can get records from other places and see what patients were on in the past. But this also leads to problems. Like, too much information can also be a problem. But medication reconciliation, is a really important issue because, up to around 20% of patients who suffer an adverse event from leaving the hospital, and it's frequently related to drugs. And the adverse event doesn't necessarily mean that it's, that they die from it, but they could have had something that they recovered from. Yes, May, do you want to say something?
Oh, no, I was just wondering if we're hoping this has changed or improved with TCM, transitional care management, but I'm not sure if we have a lot of data on that because that's probably been offset by all of the other things going on in this country in the last couple of years.
That's a very good point. So this data here, like these numbers are from 2007, so they're pretty old. Most of the data that we have about what the problem is pretty old. Most of it is from 2007, 2010. The most recent studies are showing are about what to do about it. And I think with the transitional care management implementation, so most things are trying to figure it out, but I don't think anyone has, at least not a lot of people that I could find are looking at what the current situation is with the problem. But yes, I'm hoping that it has improved, but I can tell you from experience that I still see lots of issues with medication transitions. And half of these issues, are preventable. So most result from breakdown in communication, right? So basically a patient was not supposed to take something, but someone didn't tell them and they continued taking it or something like that. And so that's why medication reconciliation should start on hospital admission. I can't stress this enough, how important it is. So especially, for any trainees on board or anyone who is, doing that primary medication reconciliation when you're on service. Remember, it's important to have things documented and not only in your notes, but actually have it where people are going to see afterwards when the patient is leaving. Because if you're the one there, you might remember what you wrote in your note and what you saw initially. But if you're off and someone else is doing it, they might think that whatever tabs are updated. So home medications are updated. So basically it should be done by a qualified provider. And again, as a systems issue, it doesn't necessarily have to be the physician doing this. In some places it could be a pharmacist or a nurse could be doing it when the patient first comes in. But I think it's important to recognize who is doing this and if someone has done it completely and fully updated it. We have to confirm medications with families and patients. Oftentimes things we find in medical records, may have been prescribed, but they might not have been taking it. Attention to formulary changes. Again, like I mentioned, the amlodipine, felodipine, so that they don't leave on both, or the Symbicort and Briolipta that we use at Heart Review. And then remove old medications from your MR list. So that's a big thing. Things to avoid: leaving old medications in the EMR list and resuming them at discharge. So I've had experiences where a patient had, topical medications for a foot wound, and then they were in the hospital, they got that foot amputated. At discharge, they still had the medications ordered for the foot wound. And again, in this case, it didn't come to any harm, right? It really wasn't a big deal. It was stopped afterwards. But, it's just to show that it can happen with all types of medications. And it can be confusing, right? So to whoever is receiving that patient to try to navigate that. And then learn indication for medications before continuing them or restarting them or stopping them. So patients, like I said before, they can have medications on the list that they're not taking anymore. They were in the past. And if you just continue everything without knowing what they're for, we might make an error with that. Right. And so, there was this review on, from Agent Aging, a successful transition for older people. And basically their conclusions was that medication-related problems occur frequently when older patients are discharged from hospital. Interventions that best support older patients' medications continuity are those that bridge transitions. And interventions included self-management, telephone follow-up, and medication reconciliation activities, right? And so this is, this was a review with, I think, 24 studies. It had a total of 17,000 participants. And the interventions that they studied bridged transitions for, like, they had different levels of transitions. The ones that were up to 30 days tended to be better. And, sometimes it was just like telephone follow-ups or medication reconciliation. Having said that, there's also, been studies saying that, just having a pharmacist call and make sure that reconciliation is correct is not enough. So I think that it's, like any other geriatric syndrome that we talk about, that there's not one big solution. It's lots of things that we do on the way to make sure that things occur correctly. And then the example again with Mr. F. So his discharge med list had insulin glargine, 30 units daily, aspart sliding scale, didn't have any parameters, just take a sliding scale, and then prednisone eye drops. But then when you spoke to him, he said, well, actually, I'm not on the prednisone eye drops anymore. I got it for my cataract surgery 2 months ago. I took it for a week after that, and I haven't been on it since. And he wasn't on it in the hospital, but when he was discharged, the medication was on his list, so it was just continued. And his insulin, when we look back at hospital records, actually he wasn't eating much. His blood sugars were very well controlled without needing any insulin, occasionally needing a little bit of a sliding scale, like 2 units a day, very little. But on discharge, his insulin of 30 units was ordered again because it was a home medication. He's leaving the hospital. Let's put him back on what he was. And so, in this fictitious patients, and this is like a mix and match from different patients that I've had in the past, when his transition was made, because we had to figure out the sliding scale, how much to do for it for meals, we actually went back and looked and saw that he hadn't received anything, and he ended up not getting 30 units of insulin. But probably if he did, it wouldn't have been great for him. His fasting blood sugars were around like 110. So yeah, so these are examples of where to go. And then there's the mobility readiness that we talk about as well. And as we all know, mobility is very important. People need to be mobile to be safe to go home or wherever they go next. And so a proper assessment can preserve resources. So instead of ordering PT and OT for everyone that comes in the door, even though I wish we had resources for that, but since we don't, instead of ordering it for everyone, if we do an early assessment and see, and identify patients who are at high risk of impaired mobility and identify patients who are below their baseline, then we can get those consults early and implement resources and use resources well. And oftentimes it was seen that, when patients come into the hospital, providers forget to think about mobility until patients are medically cleared. And so once they're medically ready to go home, then we start thinking about, okay, so, let's get you home. And then the patient tells you, well, but I can't really walk, or the nurse will often be the person saying, this patient really can't walk well. Maybe we should, get someone to see that. And so that may delay discharge as well. So looking into it early. And then deciding where are they going, right? Because their mobility requirements to go home with home health would be different than the ones to go to a skilled nursing facility, for example. And so, talking about mobility readiness, we discharge many patients home with home health, right? And oftentimes we say, well, they're mobile, they have some support at home, but they really, really need that PT so that they can keep moving. They can do okay for a few days, but they really need to start going. And we send them home with home health. Well, not everyone that we send home with home health ends up getting it. So there was this study in 2016, and only 54% of people discharged with a home health referral actually got it, like from Medicare beneficiaries. And so, again, of course, if someone gets to their home and they say, no, I don't want you here, you can't do anything about that. But what we can do is ensure that home health is set up right? And that we didn't just put the referral in, but that we have a date for when someone is going to go there and check on them and making sure that can be soon. I know that with COVID, many of you might have had this experience where home health services are very limited in many areas. And so, maybe discharging with home health is not as easy as it might have been in other times. And, in 2015, Medicare spent more than $60 billion on post-acute care. And that means not only post-acute care like a SNF, but also, home health, just with care after the hospital. And, so it's a big part of the Medicare, of the expenditure, but really because it is a really important piece of the healthcare as well. And so, when counting on these services, it's important to know what services can be provided and to make sure that they're adequate for the patient as well. And then, this also goes a little bit into the equity issues. The rate, among Black and Hispanic patients was much lower. So fewer actually got home health at home, and patients who had Medicaid, who had high employment zip codes and all that. Yeah, and so, there's this is more dated from 2019, so not as old, but comparing patient outcomes after home discharge to home health versus skilled nursing facilities. And that's a common question patients have. Can't I just go home? Should I go to a skilled nursing facility? What do what's the benefit? So there was this study among Medicare beneficiaries that were eligible for post-acute care, like either at home or at a SNF, and they decided to go home with home health. And they had a higher rates of readmission, but really no detectable differences in mortality or functional outcomes. So I think that's important to keep in mind. I think that sometimes patients feel pushed to go to skilled nursing facilities. And while, yes, we're trying to, reduce readmissions, which, for me is a big deal. But if patients have support, maybe thinking that they can try home. If it doesn't work, they can come back, even though it's not ideal. And, they may end up discharged somewhere else later. Yeah, and so this is, all compared to 30 and 60 days, though, we don't see the long-term effects of this. Yeah, so Mr. F really wanted to go home, but his family could not provide 24-hour care. He had a hip fracture, wasn't very mobile, so he accepted to go to a SNF, but said, I'm going for 2 weeks and then I'm going home. Okay, and the hospital team said, yes, you can go there, you can stay for as little as you like, and you can go home in 2 weeks. And he was happy with it, he decided to go. And so, so if someone is leaving the hospital, the next step would be discharge instructions, right? We talk a lot about discharge instructions to the patients, and when you're discharging someone, you have written instructions and all that. And so is it really helpful? Well, yeah. So people have looked at this and said that, communication with patients and their caregivers really helps hospital discharge. It really helps transition. It helps them feel heard. It helps them feel like they got better care. It helps patient satisfaction. And also it helps decrease readmissions. It helps them stick to treatment more and, higher satisfaction with this transition. Having said that, this works better for older patients. And, I'm not sure if it's because older patients actually, tend to be more complex and tend to need more of this versus someone who is young, who was admitted for one issue and then let go without many moving parts. But, there have one of the studies that I found actually showed that this had a really big impact for older patients, but really no impact for younger patients. And so, this review, it was a systematic review and meta-analysis from the JAMA Open Network about interventions to communicate discharge instructions. And so again, it was like a big review, 60 trials, 16,000 patients, and many different primary outcomes. Yeah, but really, what they did see that communication intervention at discharge was significantly associated with lower admission rates. And then for discharge instructions to patients, it's really important that we focus on giving only essential information. I know that I'm certainly guilty of thinking, if the patient is here, let me share with them all this knowledge that I have, right? They fell at home. There's all these things going on. They have all these medical problems. They're right here. So let me talk to them about, they're here for heart failure, but I see they have osteoporosis, they're not on treatment. Let me tell them why it's important. Let me talk to them about all these other issues. But when patients are in the hospital, they're often overwhelmed, right? Even if you're cognitively intact, you may not be able to keep track as much of the information given to you. So always give written information and or video instructions, highlight topics. So if you have, big discharge instructions, highlight what you really want them to know. And then again, limit information to active medical issues. So Mr. F, he didn't really receive discharge instructions because he was going to a skilled nursing facility. So the handoff was given to the SNF staff. The discharge packet was sent directly to the skilled nursing facility. So he didn't get to see the medications that he was supposed to be taking. So he couldn't tell them that he wasn't on the prednisolone anymore. Right, and then the next step is discharge communication with other medical teams. And, we often think about the discharge summary from the hospital for this. So, some data from, again, really old 2007. I want to think that we're much better with this now. But, at the time, it showed that discharge summaries often failed to provide important information about patients. And, they might have a discharge summary, but if it's not in until after they see their primary care doctor or, after they're seen wherever they go. So I think we're doing better with this. I think for most of the patients that I see in the skilled nursing facility, I do get a discharge summary. I think that there's still a lot missing in terms of information, but it's certainly better than what it used to be. And so there are some rules about, discharge summaries. Joint Commission actually say that it must have reason for hospitalization, significant findings, procedures and treatments, patient's discharge condition, family instructions, and then the attending signature. All right, so there's things that have to be there, but really, you can meet these criteria with one line for most cases without necessarily giving much information. So I think it's always important to not only try to, meet the criteria, but also give information that can be useful for whoever comes next. And so this is no suggestions. This is my personal suggestions for discharge summaries from being on the receiving end. So if you have a goals of care discussion, please include it in your discharge summary. It doesn't have to be the full discussion, but saying more than patient is DNR, DNI, because knowing, when they get to the next place of care, they might have to readdress that. So saying, 2 sentences about what happened during that discussion. Associate diagnosis to medication so that we know why that medication is being given. Is often helpful as well. If medications were discontinued in the hospital, if you can point where at some in your summary is helpful, or if medications were started, explain why, or if medications changes, explain why. And you can see I'm really big in explaining why. And so, if a patient is going home, let them know, because then when they get home, they won't have that old bottle over there that they think, oh, the hospital team just forgot about this. I'm just gonna go back on it. I'm leaving on this new medication carvedilol, but I think they just forgot my metoprolol. And so I think I'll just go back to taking it because I felt well when I took it before. Right, so I think the explanations are often helpful. And so for Mr. F, unfortunately, there was no discharge summary available when he got to his SNF and was seen by someone. There was no mention made to the prednisolone eye drops that he was put on at discharge. There was no mention of why glargine was stopped. So, so I had glargine, but like his scheduled insulin was stopped and why he was on a sliding scale. And, he had been full code on admission, but was DNR, DNI at discharge. There was no mentions of conversations about that over there. And then equity issues, I mentioned some before with the home health, access to home health services. And then there's also issues, this year is from one of the heart failure studies. Also, but from the Agency for Healthcare Research and Quality, mentioning that in 2014, Black, Native Hawaiian or Pacific Islanders or American Indian or Alaska Natives were more likely than white patients to strongly disagree that staff took their care preferences and, taking care of them. And so that's, this doesn't tell us about the outcomes, but about the, clinical outcomes in terms of death or rehospitalization, but it certainly tells us a little bit about, at least perceived quality of care. And then, there's also inequity in home health services and SNF availability. For example, patients, I think, patients who are only on Medicaid will have a much harder time getting to a skilled nursing facility, right? And we end up with patients who are in the hospital for longer periods of time, and who, because you're in the hospital, you can't get daily physical therapy because we're not set up for that in the hospital, and then you end up getting more deconditioned and, worse outcomes later. Yeah, but luckily for us, Mr. F was well resourced, had secondary insurance, so he got to his SNF right away. He didn't have to worry too much about that. But, he did have issues with the lack of information about, not next steps, sorry, not next SNFs. So if you're going home, you need to know what your next steps are, right? So if someone tells you, you might go home later today, it's important to know, am I really going home? What time can I go? When do I have to have someone here to pick me up, right? When I get home, will it be too late to, I don't know, will it be too late to make dinner? Or, where do I get my medications before I go? And so information about the next steps is really important. I think this was, my way to say that lack of information about SNFs is a big deal. Like I mentioned before, oftentimes we refer to SNFs as a big black box. Okay, you're going to go to the SNF and, that's just it, you'll deal with it there. But if you don't tell patients about what to expect, they might get really frustrated. So they're used to having someone see them at least once a day in the hospital by the physician or nurse practitioner, someone see them at least once a day. If they're in a medical, in a residency service, like many of us work at, they're used to seeing, probably 3-5 doctors a day, many different people, and, therapists and nurses, many people coming around. And then they get to a skilled nursing facility and they might not see a provider for 2 days, a week, depending on where they go, maybe more. And that can be very worrisome for them and frustrating. You won't have as many nurses and nurses' aides. It may take longer for people to answer the call button. And it's not to say that we should paint skilled nursing facilities in a terrible light, but it's just to explain, hey, you're doing better. You're doing better. You don't need the doctor seeing you every day anymore. So you're ready to go to this next place where you won't have that, but that's okay because you don't need it. And I think that once patients hear that, it's often helpful for them, to go and to feel better about it. And so this can save a lot of frustration from patients and families. Sometimes patients feel betrayed. They didn't tell me that it was going to be like this. I don't trust my medical team anymore. They told me I was going to come here and I was going to go home in a week. And the first thing, they're told when they get there is, we don't know when you're going to go home, probably more than a week. If you only needed a week, you probably didn't need to be here. And so it can be very frustrating, and it can feel like a betrayal sometimes. So this is all to say, please, avoid this. Please tell patients about what to expect. If you don't know the details, and that's okay, but you can, ask someone about it. Or if you do send patients to skilled nursing facilities often, like I think most of this conversation does, please know and mention a little bit to them. And so Mr. F was very frustrated. He was seen, he arrived on a Friday. He wasn't seen until Monday or Tuesday. He was very frustrated about not seeing anyone. I've been here forever and no one has seen me. That is absurd. He was refusing his prednisone daily because thankfully he was cognitively intact and he knew he wasn't supposed to be on it, but he still had to tell people every day, I don't want to take it. I'm not supposed to take it, until he was seen and it was actually stopped. And, the first thing he said, when, he saw the team was, I want to leave here because I hate the care I'm getting here. I would be better off at home, even without, my family there all the time, because things aren't happening here. And so, if you go with the expectation that you'll have therapy on the weekends and you get there on a Friday afternoon, you may or may not get an evaluation over the weekend, things may change. So again, this is not one patient, it's a mix of patients and things that I have heard. Oftentimes, once they, we come and we explain what's going on, they are okay with it. They don't mind not be seen every day, as long as they know how to, contact you if they need to. They often don't leave against medical advice. They will stay for their rehab until they are feeling better. Even if it means that they stay for more than 2 weeks, even if it means that you have to talk to them every week about, how they're doing at the time and seeing what they need to go home. But I think it's just really important to communicate that. And then, I spoke a lot about things, that we find to make transitions better and safer from, the medical perspective. And it is, of course, focused on patients, but also we're trying to focus on, the main endpoints for those things were, preventing hospitalizations, preventing increased healthcare costs. But there was actually, this, it's this study, and it's like it from JAGS, and that mentioned components of comprehensive and effective transitional care. And this is a more recent one, 2017, which is already in line with when we started talking about transitional care as a part of the system. But this actually focused on patients and caregiver issues, right? And so through specific points of transition. So they identified several places where the gap exists for patients and caregivers. And even though this kind of goes along with all the other things we mentioned, I think it's important to mention separately just so that we can pay attention. So, lack of patient or caregiver engagement. So especially in times of COVID, families aren't in the hospital all the time. So we see patients, they're cognitively intact, but it's our 85-year-old lady who daughter has always been helping her with her medical, appointments, because even though she's cognitively well, she likes having that support, but then we're not connecting to, the family. The patient is telling us, yes, I'll go home and I'll have my family member there with me all the time, but this family member is not being engaged in the conversation early on. And then when you talk to them, they say, well, I am home, but I'm working from home. I can't be, a hands-on caregiver 24 hours a day. And so, you have more barriers. Poor continuity of care. So not knowing who to call when things happen after you leave the hospital. Inadequate preparation. So if someone has poor health literacy, but that wasn't identified, and you don't make the instructions well adapted to them and don't explain things in a way that they understand. Also, all information is given at once when the patient is ready to leave. So, sometimes we don't give them enough information and they ask something about their follow-up or medications, and we tell them, don't worry, your nurse will give you all the papers when you're ready to leave. They'll bring you a list with all your medications and they'll have everything you need to do. But then they get that when they're 30 minutes from leaving the hospital. And if they have a question with that, who is going to answer? The nurse may know how to answer or may not, but also it's a lot of information at once. So, maybe we should be thinking about information that is critical for them, having it ahead of time, maybe even printing it out ahead of time and giving it to them when we see them. And then, gaps in service, if, they need to have a follow-up that wasn't scheduled when they left the hospital and they have to call and it's really hard to make that appointment. Or, again, limited collaboration if the healthcare team is making decisions without the patients and families involved and asking their input. And also for patients who have complex treatment regimens, it is, you have more opportunities for errors and for issues. And so patients often feel overwhelmed. And one more study that I didn't mention here, but there was a qualitative study done in the UK with their NHS, and it was asking, I think, and so it was looking at what made good transitions, right? It was saying we can make really good transitions. When does it happen? And in that case, they actually said that complex patients had better transitions because everyone was so focused and worked in on that. And there's also, been things showing that better transitions occur when the team works well together. So when people know each other and, they communicate better and they trust each other better. And so, that is also an issue in a healthcare system when you have lots of turnaround. So like you have in skilled nursing facilities to receive patients, or even in the hospital when you don't have enough people. So, and some part of it is you can't change. So if you have a resident team that's coming in and out every month, really, it does change every month. There's no way around it. But maybe, making sure that there's some cohesion during the time that people are there. Because again, when they know each other better and they trust each other better, they communicate better, and it goes for better transitions. So any questions?
Isabela, I'm seeing a lot of enthusiasm in the group for us to make sure that expectation setting for the SNF is necessary. And I don't know that it's done. We all have great suggestions, Annie, and I think we all do it at the bedside. We talk about, oh, you're going to get more rehab, but maybe I don't think I actually tell them what they're not going to get, which is 1 or 2 visits a day from physician providers, daily reports on blood draws. And so I think this is an important point that we should probably I'll check in with Asmira, and because, CCNs are overseeing social work, just to see what is the discussion with patients about expectations. I mean, the weirdest thing, of course, is, when they come back with a soft tissue infection or a hardware infection, they blame the SNF. And it's like, no, that came from your body. It went into your joint. But, so there are all these misconceptions about what happens and doesn't happen. And I think we probably should circle back and see what's being told to them from non-physician providers.
That's true. And yes, Kate.
Oh, I was just saying, TON put together, and the post-acute care service put together a nice information blurb for patients who are going to SNFs and families to look at. And I'll send the link to that. I don't know if that's being handed out to patients.
No, it's not.
But I can send you the link. It's really well put together to describe what you do and don't get at a SNF.
Yeah, I've seen that, and it is great. And there used to be, what happened with COVID was remember our pictures used to be on little handouts with this is your team and all of that stuff went away, except for our ugly menus, which keep getting passed around over and over again. And a lot of stuff has not come back, Kate. So I think this should go back to Asmira. And I know he's so super busy. If anyone knows of a different contact we can use, let me know. I bug him for everything related to discharge from Harborview.
That's a good idea, right? Even giving it to the social work team, so that when they go talk to the patients about, even because they always talk to patients about, what your preferences are for locations and places, maybe at that point already kind of giving the handout and saying, this is what we're doing, I guess. And then, at least for our Med G patients, we could, maybe also have it with the residents, I guess, not as part of the introduction, so that it's too many things already, but yeah, things to think about.
Yeah. But again, a lot of the handouts were removed because of COVID. We'll see what's what's allowed. Yeah.
Wayne has his hand up, I think.
Hey, Isabella, thanks for presenting this morning. I'm kind of having deja vu all over again. Because quite a while ago, at the beginning of my medical career, I was involved with an organization of doctors promoting house calls, American Academy of Home Care Medicine. It still exists. I'm not very active in it anymore, but this was like 35 years ago. And there was a geriatric cardiologist at Barnes Jewish in St. Louis named Mike Rich. He worked with a nurse practitioner who had outstanding interpersonal skills, very energetic, and very knowledgeable. Mike is a terrific cardiologist, but he looks a little bit like the guy in Beetlejuice. If any of you have seen the Beetlejuice movie, kind of crazy hair sticking out. Anyway, his nurse practitioner rounded with him on heart failure patients, almost all of them elderly. And they did a randomized trial, which was the lead article in the New England Journal about 35 years ago. They randomized people to get an in-person house call from the nurse practitioner 48 to 72 hours after discharge versus usual care. And what that resulted in was a shorter length of stay for the intervention group, a 50% reduction in hospital readmissions, a 50% reduction in cost of care. That was replicated by a guy named Peter Bowling in Richmond, Virginia, same design, and actually also by Mary Naylor, whose paper you just quoted a minute ago, on the west side of Chicago. And this was quite a while ago, but the result of all that research, which presented in major journals, was kind of a big yawn. People thought, oh, wow, that's interesting. but nobody really implemented it because there was no incentive 35 years ago to do that for many health systems. But that was a powerful intervention. Mary also did a study where she compared it to a phone call from a nurse practitioner 48 to 72 hours after. The in-person house call was head and shoulders better than the phone call. But that takes some energy and some doing. That's pretty, it's high touch, low tech, but pretty work intensive. Did you run across much about that in recent literature?
No, not about home visits. I guess there was one that I didn't look too much into because it was just from, I guess I should have, it was nurse practitioner oriented from home to home, and I can look more about it, but I don't remember how recent it was. But it was focused on just patients who were already homebound beforehand.
Right. Be interesting to see if that comes back around again.
Yeah, no, I think I didn't see a lot of that. I think most interventions are trying to do phone calls or video conferences now. And I agree that having that hands-on makes a lot of difference. You can actually get the medication bottles in their homes and trash whatever they're not supposed to be on, for example. So.
And the whole system is just not set up for what we're trying to achieve, like the siloed clinic, hospital, SNF, all of the errors happening at all the transitions, like big picture, vulnerable older adults, like people who are, the PACE program is a great model of doing it right. You have the same team, no matter where the person is, they follow them, make sure everything is smooth in the transitions and knows that patient. That's a great model. For our patients, unless you have an advocate on the, like a family member or a doctor who is going to call the ER when they see their patients alerted, admitted to the ER, or some sort of change to the system, it just is not smooth, and the whole thing needs to be blown up and reconfigured in order to fix this. And really what especially our most vulnerable patients need is someone who follows them throughout all of those transitions. And even some of the things we have set up, it'll follow them clinic to hospital, but then if they go to SNF, it goes away. So even within our own system, we have a lot, especially within our own system, we have a lot of work to do. So also, I called an ER yesterday and talked to an ER doctor about a patient of mine, and they were like, why is this primary care doctor calling me? I was like, it's because I want you to read this post form and know about my patient. And it actually made things more efficient and everyone was happy. But it shouldn't be unusual for teams to communicate across care settings.
Yeah, and I've seen here some questions about, but yes, Kate, I think it's always interesting when you call the ER, you never know how it's going to be received. Generally, it's been well received. Some people do sound like, why are you even calling me about this patient? But if I just saw them because they're sick at the SNF and I did these things and I'm sending them over, that information might be helpful. So yeah, and I seen like about the question, Carrie's question about getting patients directly admitted to SNF. And I know, Kate, you said you've done it and it's very difficult. And yes, they can access those benefits up to 30 days after hospital discharge, but it is very logistically challenging to get someone directly into a SNF. From the receiving end, I've asked, and I think I've only had a couple of patients in the past 6 years that came directly from home to the SNF, and these were patients who had been at that SNF before, and so they had a hospitalization. They went home, but after a few days, they weren't doing well, and the family knew the SNF and called them, and they accepted to receive them. But after the last one, they actually said, we're not doing this anymore because it's too confusing. We don't get they need lots of documentation and different records that getting them after the patient has gone home is hard. So I guess maybe if they had been referred to the SNF before and then they went home and then the SNF already has part of that paperwork, but I know it can be very challenging to do it. I don't know how you were able to coordinate it, Kate. But.
The social work at Harborview has expertise in that. I hope Kate was able to leverage that. Shannon is very
Shannon, our interprofessional
social
team is just amazing, and they worked really hard. You have to get COVID tests and records and all sorts of things and insurance approvals, and you need some motivated champions, and we are lucky enough to have them in senior care clinic. But it's not going to happen every day. It took a lot of effort from the team to make that happen.
Okay. Bye. Isabela, thank you very much. Very timely. And yeah, if any of you know who else we should circle around to besides Asmira to highlight some of these points. And the provider should do it too, but if it was part of the discharge template to talk about what to expect and using Tan's handout or something similar, that I think that would be a real move forward.
Yeah.
Some of you are going on to Zoom with Elise.
Okay.
So Diane, was that a separate number?
Well, thank you very much for being here. Have a good one.
Yes, it is. Then I will go on and make someone the host.
Okay.
So we can-
Thank you very much.
Thank you.